All right, everybody, welcome to this first presentation over here at Manual Therapy Forum. This particular presentation was something I worked on a couple of years ago quite a bit. And you can see us partnered up with my friend and mentor, Kent Kaiser. He and I, this has been an interest of his for many years, and I picked up a particular interest in it for my time with him. And so came up with this presentation that I was supposed to give at a national conference. But unfortunately, I couldn't actually do it because of circumstances with a wildfire out where I live. So Kent was kind enough to take over that and present it for me, but I didn't get to. So one of the things I wanted to do was actually present it here and see what everybody thinks about this kind of format and if something like this might be something you're interested in the future for other topics. So as you can see, it's titled Thoracolumbar Junction Syndrome, Functional Anatomy and Manual Treatment. And you see Kent's and mine employers, and as well as the organizations that we teach with or have studied with. So on this first slide here, it says, what is TL junction syndrome? So you might hear me say thoracolumbar junction, TL junction. I don't think I'll ever actually say TLJ, but to avoid typing all that out, that's what you see here. But what it is a term that was originated by French physiatrist Robert Maine. And the earliest I think that I found that he referenced it was 1974. So you see that it says a cluster of symptoms located in any combination of the groin area, or for men, in the testicles, the lateral hip, or lower back / upper buttock / SI joint that has its origin from the thoracolumbar junction. You may also hear it called the Maine syndrome after Robert Maine, or something else that he referred to it as painful minor intervertebral dysfunction, or PMID. So here is a particular note that was taken from some of his writings that it's a diagnosis that is basically clinical. There's no type of imaging, there's no other things that you'll pick up this particular type of syndrome, and that's why it's called a syndrome. So the unfortunate part about this is for people who do get imaging, whether it's something as routine as an X-ray or an MRI, you're likely to actually pick up other unrelated pathology, disc issues or other things like a little bit of arthritis or just the typical stuff that you might see in imaging. But unfortunately, some of these symptoms or all of these symptoms get incorrectly attributed to those imaging findings. So here is a great picture from some of his work that you can see the classic referral patterns for this particular syndrome. And in a minute, we'll go over how we can identify, is this particular syndrome the case, or is it something else that's causing this patient's symptoms? So on here, you can see common referral patterns, like we said, the upper buttock region, or around the SI joint or lower lumbar spine, or down into the groin, anterior hip, or even in men, testicles, or along the lateral hip, which could be incorrectly identified as something like trochanteric bursitis. It's something that you see fairly often. So that's pretty much what this particular picture is showing. We'll move to the next one and say, well, what actually is the thoracolumbar junction? And a lot of you might just think the typical anatomical definition of T12L1, the end of the thoracic spine and the beginning of the lumbar spine. But in reality, it's a transition zone altogether. And you see that I have circled here a pretty wide, big area on this spinal model. And what we want to point out is that it could actually be anywhere from T10 down to L2. L2 is probably pushing our luck a little bit, and we probably should say L1. But the point is that we're designating this junction based on function versus straight up anatomy. And the point of that is at the T12L1 vertebrae, typically from what we're taught in anatomical texts, you'll see a transition from the orientation of the facets, where at T12, the inferior facets might be or are oriented in a sagittal plane, and the superior facets of L1 are oriented in the sagittal plane, but the superior facets of T12 are oriented more in a frontal plane. So that's the big transition there. And because of that, we'll talk about what happens later on in terms of the mechanics. So going further with anatomy, the other things to look at are some of the nerves. Now there are posterior primary rami of the spinal nerves that you see here. There's different branches. There's lateral and medial cutaneous, lateral and medial and cutaneous. The ones that we're going to look at primarily are going to be the cutaneous branches. And the reason for that is the lateral branches are more motor and sensory fibers within them. The medial branches are almost all motor. They go to multifidi, they go to rotatories or interspinous muscles. But the cutaneous branches, they go down and they actually move through the lumbar fascia, thoracolumbar fascia, and supply sensation along the skin of the lower lumbar region, even over across to the upper buttock. There's a lot of anatomical variations that I'll show you in a slide in a minute, because a lot of these cutaneous branches can anastomose with one another, and like I said, you'll see a good representation of that in just a moment. This slide shows those anterior and posterior branches, so A, anterior, P, posterior. And on the posterior, you see medial branches that can supply different things like the facet capsule, even beyond into the muscles there. Now this is the slide I wanted to show you about the anatomical variations for those cutaneous branches. You can probably see better than I can point out, but there's lower thoracic segments and upper lumbar segments, and really different pictures show you where they typically supply. This goes over the iliac crest region to the upper buttocks, and as the best thing that you can see there. But the point is that on some of these pictures you can see that they anastomose with one another, and they're not all perfect in terms of where they normally supply. So like in a lot of anatomy, there are variations, and we need to keep that in mind. Here's also a picture representing those different cutaneous branches, or also called cluneal nerves, as they come out and pierce that lumbar fascia and supply areas over the upper buttock. On the picture on the right, you can see how those segments go to the more lateral lumbar region as well. This picture is excellent because it's actually on a cadaver instead of just some other drawing. And here you can see those cluneal nerves as they cross over the iliac crest. On the further to your left, that cluneal nerve you can see actually goes along the SI joint. The ones on the right go more along the upper buttock. So that's one of the reasons why we want to point out the different cluster or different ways that this particular syndrome can present. So here we want to look at the primary movements of the region, the thoracic spine versus the lumbar spine. Now, traditional thoughts about rotation, you would think that the lumbar spine has very little rotation compared to the thoracic spine. And that's typically true for what you look at when you see somebody's regular active range of motion. For the lumbar spine, they typically have, from what you see in the textbooks and literature, about 2 degrees of rotation per segment, which when you think about it is not very much. Add up all the lumbar segments and you get about 10 degrees of rotation. So the majority of rotation that occurs is more likely in the thoracic spine, certainly. But the thoracic spine does have limitations due to the rib cage. So some people have more stiff rib cages in thoracic spines, other people have more flexible, depending on age, typical function, daily tasks that they might do. But the thoracolumbar junction is something that we want to point out is free to rotate without much limitation in comparison to those areas above it and below it. And we'll go into reasons why in just a minute. So here's a biomechanical explanation of some different things with this region here. Overall, some quick things to point out that doesn't perfectly show it in the picture here, but in the lumbar spine, the instantaneous axis of rotation is more posterior in the lumbar spine, more for those posterior elements. The instantaneous axis of rotation in the thoracolumbar junction is more along the anterior in the middle of the disc, which makes it much better for rotating instead of having more of a shear component or transitory component compared to the lumbar spine. This next slide here, what we have highlighted in green, is the thoracolumbar junction. So a couple of things to point out here. The spinous processes of T12L1, you can probably see here, are, I call it like the teapot in the little song, The Teapot, I am little teapot. They're short and stout. The facets of the inferior articular process of T12 are more like the lumbar region, like we said before. They're more sagittal. They restrict axial rotation quite a bit. But the orientation, not T12L1, but T11, T12, or even T10, T11, we'll see in a little bit, they do not restrict axial rotation. Now, one of the things to point out there is that the laterally transverse processes, they're really small tubercles. They have a mammillary process that's larger and more superficial, but the transverse processes themselves aren't very big either. I mean, the head of the ribs 11 and 12 articulate into the vertebral body at the base of the pedicle, but they don't articulate with the transverse process. So there's no costotransverse joint for ribs 11 and 12, T11, T12. And as you all know, ribs 11 and 12, they're floating ribs. You can see in the picture on the top left that they do not attach through any of the costocartilage. So that means that they're detached, they're not articulated with the transverse process, they're free to move, and they permit movement into this area, T11, 12, very, very easily. And for that reason, the primary movement, depending on who you talk to, would be rotation. Now, on this next slide here, there's something else that I found in researching this topic. This particular author, Oxland et al., they actually demonstrated that rotation in the thoracolumbar junction is the least amount of movement, which, again, goes against everything I was saying leading up to this. But I wanted to point this out because, it's out there in literature, so I think you need to know about it. But the study was not without limitations. They really only studied T11, T12, L1 vertebrae and discs. So, they did leave out other segments as well. But it is interesting to note, the side bending and extension were the greatest amount of motions that they found. So that may give us something to think about when we go to apply our manual interventions, whether we're mobilizing, stretching, or manipulating. Now, Robert Main, when he came up with this syndrome and coined it TL junction syndrome or Main syndrome, there were different tests that he utilized in the clinical tests. And he came up with this cluster of signs or symptoms related to this particular syndrome. And they're listed out here that you can see. So we'll go over each one individually as we go along. The last one, a diagnostic block with procaine injection, is something that us as physical therapists or manual therapists are not likely to do because that's not within our practice act. But one of the couple of things to point out, one of the things that he noted and that he used was cellulalgia. So the skin fold is thickened to a greater or lesser extent, and pinching and rolling it will always elicit tenderness, one side versus the other in these type of patients. But also evidence of what he called myalgic cords, which palpation will show hardened or tender bands in some of the muscles supplied by the same nerve. So you may even think of trigger points or other things like that some might use dry needling for. So this first one here, and apologies as these slides go on, some of these pictures didn't scan great. So you'll see darkened areas in some of the pictures coming up, but I think, you'll still get the point. So on here, for his clinical assessment, he would have patients lay over the edge of the table, and you can see for this particular drawing that the trunk and the pelvis are on the table and the legs are hanging off the table. So here you can see that he's palpating along the iliac crest, palpating for those cluneal nerves, those cutaneous branches. So you're looking for those cutaneous branches along the iliac crest, and your pressure on the is on the precise point where these cross over the iliac crest. And if you palpate it correctly, and this is particularly positive, it's likely to reproduce some of their symptoms, or it will be much more sensitive on the symptomatic side versus the non-symptomatic side. So this positioning obviously is promoting more flexion than extension. It helps the patient to relax a little bit. You can start either direction you want to, but he classically started along the PSIS and gradually worked around and up and around the iliac crest, trying to find the most tender point. Again, the biggest thing you want to do here is palpate the opposite side as well, not just the symptomatic side, because sometimes it may not perfectly elicit their symptoms, but there will be a difference in sensitivity for the sensitive or the symptomatic side versus the non-symptomatic side. The next slide here shows the skin rolling test. So you can see right there is along the upper buttock, below the iliac crest. So what you want to do is grasp a piece of skin, big enough to hold it, and you're going to be rolling it back and forth in your fingers, or in your thumbs. So you can grasp one section, roll it back and forth, pick up another section, grasp it, roll it back and forth, and just continue on. I've even done this up above the iliac crest, and you do it enough, you're not pressing any harder, you're not rolling any harder, or you're certainly not pinching. That's not the point here. You don't pinch, you just grasp and roll the skin back and forth between your thumbs and fingers, and it will either reproduce their symptoms or, like I said, be much more sensitive on the symptomatic side. So, sorry, here's where some of the scanning got a little difficult here. But what you see next is evidence of specific involvement in the TL junction region. You can see in the upper part of the picture, Maine was using his thumbs in particular to apply a lateral translatory force on the side of the spinous process. So it would go from upwards of T10 down to something like L2, and you're applying a lateral force along the side of the transverse process, in essence, to apply pure rotation into the segment. So you're pressing on one vertebrae, so T10. How does that feel? Go down to T11, repeat, T12, repeat, go so on and so on. And again, what you're looking for is, does it A, reproduce their pain, or is it B, more sensitive on the symptomatic side versus the non-symptomatic side? And the direction may be a little different, so it doesn't necessarily have to be on the side that they have their symptoms. It could be on the opposite side, but what you really want to pay attention to is which segment is it. And particularly with this one and the next test that we're going to do, you want to make sure that you don't pinch the skin, and it could give you a false positive. So you want to just be very careful, skin locking, not pinching the skin between your finger and the spinous process. Now here's the next one. Again, sorry, I apologize about the particular picture and how dark it is, but you can use your index finger, middle finger, thumb, whatever, but you're applying almost a deep palpation or deep friction along the facet joint of the thoracolumbar region. So you can start at T10 and work each facet joint down toward L2, and you're doing what was quote-unquote a slow, gentle rubbing motion with your palpating fingers or thumb. So you would go just lateral to the spinous process, and obviously definitely not far out to where you can palpate the transverse process and or the ribs, the floating ribs. And you would go just, again, slow, gentle rubbing motion. And does that A, reproduce their symptoms, or B, become much more sensitive or more sensitive on the symptomatic side versus the non-symptomatic side? As we said before, you want to make sure that you're not creating a false positive. You can see in these different pictures whether you're pinching skin against bone or you're irritating a joining structure or a different structure than the one you're actually trying to palpate. So, how in the world does this become a problem in the first place? Well, in experience for myself, for other people, really the mechanism of injury is thought to be from rotational movement, twisting movement. Usually can even occur, combine flexion and rotation, which, when you think about it, is also the typical presentation for somebody that may have a disc injury. Disc injury can refer pain to these areas, but this is something that is often missed, thoracolumbar junction, especially if the person's had imaging from a previous provider and have been told that their symptoms are all related to lower lumbar dysfunction, disc issues, whatever kind of combination you want to think of. Our point is that it doesn't always have to be down there, and in many cases, depending on their presentation, it isn't. So, going beyond the syndrome, all the stuff that we talked about, let me back up for just a second, actually. So, ideally, when you look through all this cluster, when this is strongly positive, I would say at least 3 of those will be positive, if not all 4. And again, just keep in mind, they don't necessarily reproduce the patient's pain, especially if it's testicular pain or groin pain, other things like that. It doesn't necessarily reproduce that strongly, although in some patients it will. Again, you're making sure, is there a difference in sensitivity between one side and the other? So as we move forward back to where we were, we want to think about characteristics of the thoracic spine. There's different things that we can look at, and in the next slides that you'll see variations of anatomy within the thoracolumbar junction. This particular area is very, very important as a link between the lower body and the upper body because it facilitates movement through this area. It doesn't restrict it, and it really allows us to function in various ways as one whole being, whole person, because like I said, it connects our upper body and our lower body through this area. So if you can't have proper motion through this, it can really certainly limit movement, limit function, and or contribute to other stresses above or below it. Now this particular picture comes from an article by Singer and Bridal, I guess is how you pronounce it. And it really shows the difference in orientation of the zygapophyseal joints in this thoracolumbar junction. And what they noticed was there's differences in anatomy. So the tenon and mortise concept, if you think about it, a tenon and mortise, as you see in the picture here, is basically a locking mechanism in carpentry, is also contributed to anatomy here because, as we talked about before, traditionally in anatomy texts, you see T12L1 where the upper facets of T12 are more frontal oriented and the lower facets of T12 and then L1 as well are more sagittal related. So that lower junction of T12 and L1 is locked. It provides a locking mechanism where there's very little rotational movement through that area. And consequently, the segments above it, T10, 11, TL, T11, T12, have much more freedom of movement. What this particular article noted was there was much more anatomical variation of the subjects they studied and said that tenon and mortise configuration was actually most frequent at T11-12. So, this particular sample size, when we're doing our motion testing or palpating, we want to keep that in mind, that textbooks may say T12L1, but it may be, as the findings of this article stated, more frequently at T11-12. So just to keep that in mind. Here's a great representation of that T9 and mortis and the orientation of the facet joints. You see here in the middle picture, the superior facets of T12 are more frontal oriented, like we said, and the inferior facets of T12 and the upper facets of L1 are more sagittal in their orientation. So again, moving beyond the TL junction syndrome, other things that we want to consider and think about are just the overall function of this area. So the lumbodorsal fascia, thoracolumbar fascia, these particular tissues are hugely related in providing stabilization in this area, but also could impair or limit movement as well. So it's not just the thoracolumbar fascia and all the tissues that adjoin that, but as well as that, the diaphragm. Because you can see on the pictures of the left, you can see how far up those diaphragm tissues go, as well as how far down they go. In the picture on the right, you see the crura of the diaphragm, and those fascial attachments go right along that thoracolumbar junction. So again, different things to think about in terms of what could be limiting movement, what may not be limiting movement, and things that we overall want to at least assess when we're looking at the patient. Now, one of the things that we also need to talk about with this area is pathology, especially in this area, serious pathology, because one of the things that we have always been taught, especially by Cyriax, Dr. Cyriax, whenever he was educating people of this area, would say this is quote-unquote the forbidden zone, where if you actually have symptoms localized to the thoracolumbar junction, it's probably a bad thing. It's probably not a good thing. It's very unusual to have pain around this area without severe pathology. Usually if you do have more of a somatic dysfunction, irritation of a zygapophyseal joint, something like that, it often can refer elsewhere and is not particularly localized just to this one area. As an example, if you have a disc herniation of the thoracolumbar junction, those can be very difficult to diagnose because they can present in so many different ways. You could have upper motor and or lower motor neuron presentation depending on which part of the cord is affected, as well as the nerve roots or cauda equina. So that's a very odd thing to notice, and it, in particular, if for a different type of patient, if you're suspecting cauda equina, you want to make sure that you have imaging that goes into the thoracolumbar junction area, not just down to that mid and lower lumbar region. Anyway, as we want to go along there, we talked about before thoracolumbar junction being that region T10 to L1, L2. There are different biomechanical changes, like we said, variations depending on the location of that lower part of the cord. As we're taught, usually the lower part of the cord ends L1, L2, and that's why I say depending on if there's a disc herniation in this area, it can present as a lower motor neuron lesion, upper motor neuron lesion, or even cauda equina, depending on which part of that cord or terminus of the cord gets affected. All right, when we're screening for serious pathology, these are important things to think about. Your patient history is very important and it's key. So you can see there, typical things that we're taught in classes or textbooks, the stuff to ask for, specific questions to ask for. Constitutional signs and symptoms to be aware of, all these things that might raise our awareness or raise potential for red flags. But other significant findings as well. And this is important. Can you alter their symptoms with movement? Pressure, overpressure, resistance. If you can't alter their symptoms one way or another, That's not a good thing, and especially if you combine it with some other constitutional signs or symptoms. That means we're not dealing with a musculoskeletal presentation here, and this person needs to be seen by a physician right away. Do they have a history of infections? Do they have a history of cancer? History of cancer, even if they've beat it and they don't have cancer, scans and everything show nothing. Even if they have a history of cancer, it is a big red flag to consider in that person's presentation. Just because they've had a history of cancer and you can't figure anything else out doesn't mean that they have a tumor. But it is, in statistics and research, very high level of suspicion if other things aren't adding up. You want to keep that in mind. So what do we look at? We're going to look at active range of motion. So do they have, like it says here, is there total splinting of movement in all directions? There's a possibility of a fracture there. Do they have symptoms in the lower extremities, or in particular the abdomen? If it's worsened with flexion, there's potential for disc herniation or other space-occupying lesion. Do they have no alterations with symptoms of their symptoms with range of motion? Then you want to think maybe there's something that's not musculoskeletal. I know some of this is probably common sense for all of you, but we still need to mention it. Now, dural signs. This is something that we also want to make sure that we screen out with the thoracic slump test. And the point that I want to make here, as you can read there, you must have a change in symptoms or pain when you're moving either the head or neck or the ankles. You must have motion occurring with both legs for this to be a true thoracic slump. You can't just do one or the other. You need to have both legs moving or both ankles moving to really pull on that cord versus those more peripheral tissues. So in this test, you would have the patient sitting. You would have them raise both legs up. Or actually, let's back up. You would have them sitting, and you would slump down, and you could move the head down into flexion as well. Does that change any of your symptoms? Yes or no? And then you can have them straighten both legs. Does that change your symptoms? Yes or no? And then you have them dorsiflex both ankles. Does that change your symptoms? Yes or no? So if they report along the way of that gradual tensioning any reproduction or increase in symptoms or pain, you get suspicious. And those symptoms could be anything from the abdomen down. If that is the case, you want to reduce the tension, so they raise their legs up. Does that change any of your symptoms? They say yes. So you hold them there, and then you have them lift their chin up to reduce that tension from above. Does that change your symptoms? They say yes. You say, okay, what is it, better or worse? They say it's better, then that's a positive. Because that mechanical stress to the dural system increased their symptoms, but when you took that mechanical stress off from above, it reduced their symptoms. So you know that there is some kind of mechanical sensitivity for some reason, some inflammatory reason along these tissues, and they don't like to be stretched. So same thing could be if they dorsiflex both ankles, you've made it that far, and it made things worse, reproduce things. You have them move their head, and it changes things again. So that's a quick example. We could go into a lot more details about that, but that's a quick example of what a positive test would be. Negative test, you move the head, you move the legs, you move the feet. It doesn't change their symptoms. It stays the same. So we would classify that as a negative. Now, reflexes, other things to screen out serious pathology. We're looking at deep tendon reflexes in the lower extremities in particular, so usually at the knees or the ankles. And the biggest thing that you're looking for are, like it says here, obvious signs of hyperreflexia, not just exaggerated reflexes. So usually you think of a brisk reflex as something where you get a quick jerk when you tap appropriately on the tendon. And a hyper reflex is something where it's a huge jump, like way above normal what you would ever expect. And there could even be some spasticity associated with it if it's an upper motor neuron lesion. As always, you want to compare one side to the other. And if there are significant differences from one side to the other, you could have one that is hyporeflexic or has no reflex at all, and the other one is brisk or normal. Again, that's not good either. So you just want to keep those in mind, and you would rather not only look for one particular thing like hyperreflexia, but differences side to side in addition to that. Other motor neuron signs you want to look at would, in this particular case for clonus, you need to make sure that you keep pressure, tension against the foot when you're checking for clonus. You can't just push on it really quick and then let that pressure off, because you'll get a false negative. So you need to rapidly dorsiflex the ankle and maintain that pressure to determine is there any clonus. Now, it's normal to have a couple of beats of their foot against yours when you're checking for clonus, but anything that is above 3 beats is no good. This classically qualifies as positive for the presence of clonus. But you also want to look side to side as well. If you have 1 beat on one foot, but you have 3 beats on the other foot, that could still be something that you want to keep in the back of your mind as a finding, especially if it correlates with other clinical findings as well. Or if other things aren't adding up and you have that as a one key finding, then that could be something that in your clinical judgment causes you to contact the referring provider or contact a physician and just say, I'm really suspicious about something in this area, things aren't adding up. Could we get some testing of some sort to determine if there's some nasty stuff going on? And again, for upper motor neuron signs, we have the Babinski sign, which is scraping of the dorsum of the foot, the plantar side of the foot. Typically, is with the reflex hammer, you start at the heel and you go along the lateral portion of the plantar surface of the foot, and you kind of wrap around along toward where the big toe is. But if you've ever actually examined anybody with these upper motor neuron signs, just any noxious stimulus along the bottom of the foot will elicit that Babinski reflex. And Babinski reflex is typically classified as extension of the great toe. You could see even other things like splaying of the rest of the toes as well. But that's what you're looking for. So this is what we would typically advise, before we're going to move on to any lab portions of a presentation like this, is, hey, let's do some screening. Let's just be safe, make sure nobody's got some things that they have no idea is going on with their body. And we would go through all the different stuff that we checked before, active range of motion, check some reflexes, do the thoracic slump, and just see if there's any presence of upper motor neuron signs in these participants. So that's where we would take a break here and go into that. So if you want to check that on yourself or a friend, go right ahead. Now here is something that's pretty interesting. As I was researching a lot of these topics, are further possible pathologies in this area. And we kind of take a deep dive into it, so indulge me for a little bit. So some of the things that are concerning in this area, thoracolumbar junction, may be tumors. And let's kind of put this into perspective. Any of these serious pathologies that we're talking about are rare. They're extremely rare. But if you do have a patient that comes in your door, you don't have to make this diagnosis, obviously, if it's not in our Practice Act. But these are things to consider and keep in mind when you are finding things that are inconsistent, that don't match up. So when we talk about tumors, there's 2 main types. There's either intraspinal or intracanal, or extraspinal. So intraspinal, there's split up in different ways. There's either outside the dura or inside the dura. And then if it's inside the dura, is it outside the cord or is it inside the cord? Now, here's some commonalities. If we're looking at tumors in particular, as you can see here, benign tumors, they usually happen along the posterior elements and usually in younger people. Now, when we're taught about cancer and tumors in general, we're usually taught about, a risk factor being 50 years and older, right? So you can see here, malignant tumors are usually more of those anterior elements of the vertebrae and are a lot more common in 50 years and older. So that malignancy is obviously a very bad thing, but I wouldn't want a benign tumor either. That can still cause a whole lot of problems. So anyway, as we look at those tumors, multiple myeloma is the most common form of primary cancer of the bone, meaning it doesn't metastasize from another cancer located elsewhere within the body to these vertebrae. However, though, as you can see in the slide, this area, as well as other parts of the spine, it's actually more common to have a spinal metastases than it is to have a primary bone tumor. So that's why we always want to ask the question, or at least have that in some kind of pre-screening paperwork that the patients are doing. Do they have any history of cancer? One of the things that we can check out in terms of that, like I said, is questionnaires or other things if we're not going to specifically ask that question. Unfortunately, for whatever reason, these spinal metastases have a tendency to be along this region that we're talking about. Another thing to mention here is that if you do have a metastasis to the vertebral elements, especially those posterior elements, it's very common for the patient to have this full articular pattern, which is basically just saying that they have a painful limitation of extension and symmetrical loss of side bending and rotation, both ways. They could even have a lot of muscle spasms present. They could even be tender to palpation along the spinous processes, or if you do some percussion with like a reflex hammer along the spinous processes as well. And as we said before, if you have any tumors along this region, their presentation can be very different depending on where those tumors are located. They could have more lower motor neuron signs and symptoms if it's more of the lower part of the TL junction, even present as a cauda equina as well. Or it could be more upper motor neuron in presentation if it's that upper part of the thoracolumbar junction. So you got to keep those in mind when you're doing your assessment. And again, if something's not right, you get the hair standing up on the back of your neck, things aren't adding up, not musculoskeletal, get them out. Get them looked at by appropriate professional. Specific types of tumors that we can talk about that may be common are neurofibromas. They're most commonly, as you can see here, primary tumors of the spine, and again, most often in the thoracolumbar junction. Now, we said before, in this area, it's even more common to have secondary tumors or metastases, but for this particular tumor, neurofibromas, these are primary tumors. So you see the age that is most commonly diagnosed. You want to keep that in mind. It's kind of hard to actually diagnose this particular tumor early on, at least, because a lot of times they may mimic a disc lesion. But remember what I said earlier, if you have a particular presentation that has a more of a discal origin in this area, that's still considered a red flag. So if that is the case, you'll be getting them out early anyway. So over time, you see this is a slowly progressing type of tumor normally. So their pain usually worsens over months or years. You can feel it sleeping. So they may prefer to be sitting up in a recliner. Again, those typical things that it gets unchanged with activities or movement. Here, though, for this particular thing, side bending away from the painful side this is odd. I don't have a great explanation for this. This may be the only painful or limited movement they have. And some of it has to do with the type of tumor it is, where it's located, and how it gets stressed during particular movements. So everything else being equal, if something isn't adding up and they have that particular presentation, side bending away from the painful side, may be the only painful or limited movement, you definitely want to keep that in mind. Now, when we talk about metastases, frequently these are the type of cancers that will metastasize. So any patient that has a history of cancer, in particular these cancers, we need to have that suspicion in the back of our head. At any point, we need to have that suspicion. So you can see up to 70% of primary tumors from these above cancers can develop mets to the vertebral bodies in the thoracolumbar spine. And when I say thoracolumbar in this instance, I mean thorax and lumbar spine. Okay, here is a quote that I got from one of our sources or references that you'll see in the back of the presentation here. But this is so important. I even, emphasize part of the quote here, because oftentimes we expect imaging to reveal our suspicion, and the unfortunate reality is the biology may not cooperate with us at the time, or the pathology may not be what we expect at that time. So you could catch something early and you could be an amazing clinician in that regard that may not show up on certain imaging like an x-ray. You still need to have a suspicion and awareness of things that are going on and things that don't add up. And hopefully you have a good enough relationship with a physician who would understand your concern and trust you, and be willing to order some other imaging as well. So on this, I don't need to read it to you, but the important point is that 30% mark of bone mass for something to become evident on an x-ray is huge. And if something is slow growing, you may not pick it up right away. So if that is the case, do not manipulate. And when I say manipulate, I mean high velocity, what we typically call high velocity, low amplitude thrust techniques in this area. Bone scans are great for picking these type of pathologies up, so that may be something that you advocate for with your patient if an x-ray doesn't reveal anything. Now, spinal canal stenosis, central stenosis, is something that we can also look at. There can be either a congenital or degenerative aspect to it, but it's more of the posterior elements. It's usually a pretty odd presentation in this part of the spine, the thoracolumbar junction region. So that's why it says here it's rare to occur without some other, metabolic or orthopedic problem in this area. And you can see signs and symptoms, pseudoclaudication in those typical areas of the lower back, upper buttocks or buttocks, thighs that you want to look at. You could even have paresthesia. And something else to differentially diagnose would be something like a claudication. In this particular instance that I'm talking about, intermittent claudication usually happens with activity, and it's relieved with resting. So activity could be walking, biking, other things like that. But resting, whether it's stopping, standing still, or stopping biking or doing any other activity, would relieve those symptoms. If they are present with activity, you want to make sure that, again, you palpate different pulses within the lower extremities, and if it is intermittent claudication, you would expect those to be diminished with activity and restored or normal with resting. If we're looking at a disc issue, herniation, protrusion in this area, the pain or symptoms are usually worsened with flexion, like we would typically think of for most disc issues, but If you do activities with the lower extremities, that really wouldn't change their symptoms. So just one other thing to think about. Now, fractures in this area are actually the most common area for the thorax or the lumbar spine. And some of that could be due to the transition of forces or transition of movements through the spine. But usually, if it's for a younger person without any kind of metabolic pathology like osteoporosis, it's due to trauma. If it's for an elderly person, it's usually because of osteoporosis or other, bone weakening issues. So that could be also a pathologic fracture, as you see here, whether it's from a tumor, metastasis, infection, or even further things like ankylosing spondylitis. And earlier we said more common with trauma in the younger patient versus the elderly patient. But if we're talking about an osteoporotic fracture, it can occur with very little quote-unquote trauma. As you can see here, it could be from sneezing, coughing, misspelled coughing, sorry about that, stepping off a curb wrong, bending over to pick up something. That could cause an osteoporotic fracture as well. So just because there was very little trauma involved, that does not mean that they don't have a compression fracture, wedging fracture, other things. Signs and symptoms, central spinal pain, radiating out to the flanks or the girdle areas. If you lie in supine, it can be relieving, but the other things, tenderness over the side of the fracture, that's where you can do your tapping, your percussion with the reflex hammer. Segmental wedging or kyphotic deformity as well. And, when you're talking about range of motion, flexion is going to be, the most reproductive or painful. Now, other things that we want to point out include spinal infections, and there's different things that can be infected, and they present differently as well. First one is pyogenic from a vertebral osteomyelitis, as you can see. It occurs a lot in the lumbar spine, but it's mostly with a staph infection. So that's why, again, we want to ask our patients, have you had any recent infections? And that can also be traced back to, as you see here, extraspinal infections like a UTI. So especially for our female patients, have you had any issues with infections in the past X number of months? Whether that be a staph infection, those can come from fingernails or whatever, upper or urinary tract infections, other things. You want to make sure that you're asking your patients that. These presentations can come on slowly, and they can be local to where the infection is. So it doesn't always have to be where their initial infection started. Through vascularization and the way the blood moves, it can find its way anywhere. And this is one of the reasons why, kind of off topic, dentists and other dental professionals, when they're doing work for their patients, they always ask, have you had any type of joint replacements or other things? Because if there is any kind of infection that originates in the mouth or the teeth, it can find its way into those joints that have been replaced. So as that goes on, this is something that, again, we always need to watch out for. Okay, back on topic. As the infection worsens, those typical constitutional signs and symptoms become more and more evident. So early on, it could just be a localized pain that has no musculoskeletal presentation. It doesn't change with postures or movements. It's just localized pain. If it gets worse and progresses, then that's where you get more of those constitutional signs and symptoms we referred to earlier. In addition to the vertebral osteomyelitis, there's also tuberculosis, TB, which is something that hopefully we're all screened for, especially if you work in a hospital setting. You have to get screened for that regularly. But this is something that does commonly occur in the thoracolumbar junction when we talk about infections. So it's more often presenting in the vertebral body because of the vascularity, less often into the disc for that exact reason. Unfortunately, this onset is, as you can see how I typed it out, extremely slow compared to something that is pyogenic above. And the backache is usually less severe. So it's something that's just kind of always in the background, and it gradually just doesn't quite seem to go away, kind of nagging. There, again, as the infection worsens, those signs and symptoms, constitutional, get more and more evident. Discitis is also another infection that we want to consider, or at least keep in the back of our minds. But it's a little different because it often occurs more in the lumbar spine in very, 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 very young children. Usually, if this is present for whatever reason, the fever there is a fever that comes along with pain and self-limiting movement. You have a young child like that, they're not of the obviously age or maturity level or physical development, whatever, where they're going to push through and keep going. They're going to self-limit their movement quite a bit. So that is also something else that we want to talk about. So after going through all that and talking about anatomy, some mechanics of movement, and some pathology, so what? What do we do now? Well, these are the main interventions that have been performed traditionally, whether we have specific local injections, so that could be a diagnostic injection to reduce the patient's symptoms, or a specific injection with another material that would just completely get rid of their symptoms. Obviously, that's not within a manual therapist's practice act normally, unless you're also an MD or a DO. But what we're going to be using is manipulation, mobilization, other stretches that we can do. In particular, these are pictures of, from Maine himself, of different manipulations that he could perform on a patient to improve movement in this area and reduce the irritation of these tissues. So you'll see pictures here that we've gone through, and just to illustrate to you and different ways of performing these techniques, and what we'll show you later on from my own pictures of how to perform these techniques, and we'll talk through them. Well, sorry those flags kind of get in the way, but these are specific topics that we want to hit when we mention red flags, yellow flags, or green flags. Red flags meaning do not go in to manipulate this area. In fact, if it is the case that there's a bunch of red flags together in your clustering red flag findings, they don't need to be in the clinic anyway. They need to go out and see a more appropriate healthcare provider. So that the point here is that there's evidence that you've gained from your examination that something else is going on, not musculoskeletal. So that could be visceral, vascular, neurogenic, or some other bone disease. It could be inflammatory process, whether that's inflammatory, like we said earlier, with some of the different infections. It could be something like ankylosing spondylitis, just a number of different presentations. If there's any acute or recent trauma and they haven't been appropriately screened or imaged, they need to get that done. Ataxia, upper motor neuron signs, some of these things kind of go without me having to belabor the point, but we want to make sure that we get that person screened out before we do any kind of manual therapy on them. So caution, yellow flag signs keep creeping up in your back of your head. So are there any type of neurological signs or symptoms? It may not be the red flag warnings that we saw before, but are there any other ones that come into play, differences in reflexes or otherwise? If there's any signs of hypermobility or instability, you have to be very cautious with those because you don't want to be injuring spinal tissues or even more neurological tissues. if the patient's been on steroids or other anticoagulants, the possibility to create an injury with your technique could be a big issue. Pregnancy is something that we just want to be extremely cautious with, because not that there have been any evidence of a pregnancy being spontaneously aborted with manual therapy, but if that were to happen, you just don't want that on you as a clinician. Even if there's no chance for that to happen with what you're going to do for a pregnant woman, you just don't want to go there. Marked kyphosis, meaning different disease processes or possibility of a compression fracture or wedge fracture. Unstable shoulders, that could be for what it could change with your technique, or that can be some other hypermobility syndromes. You never know. Teenagers, so yellow flags, that could be psychosocial risk factors or other things, or just the fact that their body may not have fully developed in terms of its maturity level of their skeletal system, or it could be some other disease process like a Scheuermann's disease that could be present. Mention the psychosocial risk factors. We want to be very cognizant of that with those type of patients that must have something, they always want this or that, or other things are alerting you like, maybe I shouldn't be doing this with this type of patient, for many reasons that I'm sure you could guess or think of. Okay, so if we're going to go ahead and give the green flag and say, all right, let's go ahead and go through with this, we're going to do some manual therapy, some mobilizations or manipulations. There should not be any, there should not be concerns for red flags. There should be no adverse signs or symptoms. You should have the patient's consent. And what I mean by that is you've explained your findings, you've talked to them about prognosis and what you would like to do as an intervention, and you tell them what that would involve. You could even go through and set them up and give them an example of a little mini thrust to illustrate this is what we would be doing. Is that okay with you? You may even hear a pop or a pop sound or a crack, or you may even feel that. Is that okay with you? And for consent, you want to get back an affirmative answer. You want for them to actually tell you, yes, that is fine with me. And then you want to make sure that you document that in your documentation system as well. Patient explained, diagnosis, risk factors, you want to bring those up as well. And then you can also write consent given, check or positive, or click that box, whatever you're doing for your documentation. Other things to look at is they have a segmental stiffness to PA pressure, or overpressure for PIVMs, things like that. They have not complete rigidity of the rib cage. There's some flexibility there so that it would dictate which kind of technique you're going to use. And it could even satisfy the clinical prediction rule for use in the thoracic spine as outlined by Cleland and other authors. In that particular clinical prediction rule stated, if 3 out of the 6 of these following criteria were present, the successful outcome basically went from a coin flip to over 85% success with the outcome measure that they used. And those predictive values were symptoms less than 30 days, no symptoms distal to the shoulder, neck extension did not increase symptoms, the fear avoidance belief questionnaire physical activity subscale score was less than 12. They had a diminished upper thoracic kyphosis, and cervical extension range of motion was less than 30 degrees. So this particular clinical prediction rule obviously deals with higher up in the thoracic spine, but if those things were the case, we're talking about the lower thoracic spine, maybe you could justify that. Other things to consider for thrust manipulation and its effects, you have different research evidence as we list here, but the big thing that we want to point out is from the father of evidence-based medicine, Sackett, and he talked about the three-legged stool of research evidence, clinical experience of the clinician, as well as the patient preferences. So beyond just the research evidence, if you have a clinical examination with findings that point to this particular syndrome, you're aware of this syndrome from your own clinical experience or knowledge, and you have the skills to perform the appropriate interventions, and the patient is okay with you performing those interventions, then thrust manipulation is a green light. So what we're going to show you here, obviously I don't have videos on this particular presentation, but what I can do is talk you through some of these techniques based on the pictures that are on the slides. So what I'm going to show you here is a combination of many different things that you can utilize in the clinic. As always, if you are not familiar with any technique, I would advise not practicing it on a patient first, unless you've been, mentored and obviously you're safe with the technique. There should be some self-limiting on this if you're not familiar with something, or you're not comfortable with it, or you don't feel like you're doing it well enough. I would not do this on a patient, because the last thing we want to do is harm a patient anyway. So make sure that if you're going to try any of these, you want to practice on some friends, coworkers, or other things before you actually go on a patient. The first one here I kind of teasingly call the middle school dance because of how the patient has their arms draped over you. This particular model is a male, but we still have the pillow barrier between myself and him. And my hands are contacting along the the lower part of that thoracolumbar junction. So we've done our assessment. We know which segments are limited. My hands are going to come up underneath on the inferior aspect of that segment to perform the thrust. So the person, you're both standing. I have my arms and my hands positioned around the patient. And it's kind of like doing a Heimlich maneuver with both of my hands. But what I'll do is I can lean back to gain a traction moment for that patient. And as well, you can also fine-tune it by rotating their upper body around one side or another, or even side bending them slightly one way or another to get to the hardest infield where that barrier is. So the patient is going to relax. You're going to lean back, get a little bit of traction, and then give a thrust in the direction that you see that green arrow there. The next picture, sorry, the arrow colors are going to be different from here on out, but you can see that down by my feet. This next picture is an old bone setter technique. And you see the patient, he's got his arms crossed or arms folded. It kind of helps if you as a therapist have decent range of motion in your shoulders for this. And it also helps if you're a little bit taller than the patient. But if you're not, you can stand up on a step stool or other surface that can lift you up higher than the patient. But what you're doing is my buttocks are along the lower thoracic vertebrae. And as I lean forward, I pick him up off the ground. I'm up on my toes. He is literally resting completely on me. I drop my heels rapidly toward the floor, and what that does is it brings his whole lower body, even into the lumbar spine, down, straight down. And by doing this, because of my stabilization, in theory, of his lower thoracic vertebrae against my buttocks, that those don't move, and the force coming from his lower body provides a nice distraction and even a little bit into extension for this TL junction. This next technique you can see is side lying, and here again, sorry about the colors of the arrows there, but here you can see the table is gatched to where we are locking from above with some left side bending as well as left rotation. So this would be called ipsilateral locking. And below, we're doing more of a neutral lock, where it's mainly rotation below. So here we have the table gatched up and the hinge in the table is right in that same area where the thoracolumbar junction is. And we've produced enough tension above and below to be localized to that thoracolumbar junction region. And so when we perform this manipulation, we want we want 4 different points of contact. There are my left forearm along his rib cage and shoulder area, my right forearm along his pelvic region, my palpating fingers along the vertebrae, and then contact of my abdomen or upper abdomen along the rest of his body. So to perform this initial manipulation, it's a timing emphasis between both of my forearms maintaining the position of his trunk and pelvis, and my body dropping down into the patient to perform this manipulation. So it's a lot of things, a lot of different parts all together, but the main emphasis is a dropping down into the patient while you're holding that localization with your fingers and forearms. Here is a different combination of movements, still with the manipulation and side lying. In this particular instance, we have contralateral locking from above and below. So his trunk, his thoracic spine is side bent to the right, but rotated left. And his lumbar spine is side bent to the right, but again, relatively rotated to the left. So we're still localizing to that thoracolumbar junction region. I can use my fingers or thumbs to palpate where that motion is occurring, where the tension is developing. And my forearms maintain that localization through his upper body, rib cage, shoulder, and along the pelvis there. And again, you can see emphasis is to maintain that tension through my forearms and hands while we're providing that mainly downward force into the table, into the patient, as we manipulate into the TL junction region. The next couple of techniques are in supine, and I call these more gapping techniques. And these are the typical techniques that you see that are called the dog technique, I think was coined by Fryette. And you can there's many different ways you can use your stabilizing hand. My left hand in this example, it could be flat, it can be in the pistol grip, the typical thing that you see a lot. Depending on the size of your hand or the flexibility of your fingers, you may not need anything to grasp onto. You may prefer to hold on to something, whether that's a chapstick or a pen or rolled up wad of tissue paper, whatever. You can even use silly putty or Theraputty. It also works really well. But here, you're stabilizing on the inferior segment of that motion segment, the TL junction, that you've identified as hypomobile. And I particularly like to support the patient's head and neck and their upper body while I have them, because you're having them flex up to that TL junction region, and you're using their arms crossed like they are in this particular picture. Your thrust is in the direction, as you can see, in the direction right above where your hand is. Common errors with this that I'll see is therapists will have the patient roll back too far, and they'll lose that localization, and when they thrust, it's almost harmful to the patient. It hurts the patient. So you want to make sure that you maintain that localization by flexing up to that area. In addition to that, you can also give some side bending toward you or away from you, as well as maybe just a little bit of rotation down to that level as well when you're doing this technique. Same exact thing in this picture, except this time the patient has their hands behind their back, behind their neck, and they're interlocking their fingers. This is for someone who has a lot of flexibility or has less muscle bulk, and obviously their neck is able to get into this position. This is not my favorite position or way to do this technique. I prefer the one before it. But otherwise, it's the same thing. Now here's my friend Kent. Here he's showing you the use of a wedge, a mobilization wedge. So if the patient is much bigger than the therapist, you can utilize a wedge to help perform either a mobilization technique or even a manipulation for the same things that we were just doing. So you can use that instead of your hand to block the lower segment or the lower portion of the segment you found to be hypomobile. Or here, you can use it to help take up some position between your hand and the table. So either way works. It's just dependent on the particular instance with you and your patient. So if your arms aren't long enough, the patient's much bigger than you, those are two alternatives. Now this is a particular technique that I've looked at. Honestly, I haven't used it a ton, but it's a distraction technique, mainly used in extension, as you can see, and you're propped up on your elbows to promote that extension, and you can localize through the lower extremities. So my hand is cupped just slightly so that in between my thenar and hypothenar eminences, if you bring your thumb and pinky together, you see there's a little groove between your hypothenar and your thenar eminences. And that's where the spinous process would go for that upper vertebrae. And then my other hand, my left hand in this example, is using either one or both lower extremities to isolate up to that area. So you can provide some traction. In this case, with my left hand, I could move one leg or both legs toward me or away from me to provide some side bending, but I think the main emphasis would be some traction through one or both legs to help with that thrust. So whenever you are going to perform this thrust, it's mainly through the hand contacting the vertebrae, but it's also with the other hand along the leg to help provide that traction. So it's both timed together. This could be a little difficult, but it is successful. It does work. This is a seated technique, a seated gapping technique, where I'm using a towel along the lower segment of this hypomobility that we found. I know it looks in this particular example that it's not in the thoracolumbar region, but trust me, it is. It's kind of weird the way things look on a picture, but here you've identified the hypomobility. The rolled up towel is going to go along the lower part of that segment, so along the spinous process. And in this particular example, we didn't have to do this very much, but you could also flex down toward that level, similarly to what you do in supine. And you can see how the patient has his arms crossed. My hands are going to go along the lower elbow, and we can localize again through a little bit of side bending or rotation one way or another toward the hardest infield. And the patient can take a nice breath in, and as they breathe out, I've localized. I am pulling backward toward me. I'm giving pressure through their elbows with my hands, but the emphasis is a quick thrust in the direction you see with that arrow through your hands and arms. And one of the things I like is they take a breath in, and as they breathe out, I am taking up tension through my shoulder blades, retracting, and through my arms pulling back to me. And right where I feel the maximal tension, which is usually when they're at full exhalation, is when I'll normally apply the thrust. This is a similar technique, except instead of using a rolled up towel, you can use your knee to stabilize the inferior part of that segment. This is a tough technique. Depends on the size of the patient and honestly the size of the therapist as well. If you have long legs, it makes it tough. You got to have a lot of dorsiflexion in your own ankle to make sure that you can get your knee in the right place. It is not the easiest of things, but it's still can be very useful. It just depends on your size and the size of the patient. But like you see here, my knee is stabilizing against the inferior portion of that motion segment, and his arms are interlocked, his hands are interlocked behind his neck, and my arms are weaved up through his, similar to what you would do for a cervicothoracic junction distraction technique. But the emphasis is to, for your thrust, is to bring your force posterior and slightly upwards. So you're doing also a slight traction or distraction. Now here we're getting into some different seated techniques. This kind of goes off the rails a little bit in terms of combination of movements and how you're providing locking. But here you're doing contralateral locking above. So he is side bent left, rotated right, and you're thrusting from below. As you can see in the right picture, I am maintaining the lock from above. In this particular instance, my right arm is underneath his right shoulder, and coming up and over to the top of his left shoulder is my right hand. My left hand, the thumb of my left hand, is against the spinous process of that lower portion of the segment, the lower spinous process of his segment. And so as I'm maintaining this locked position above, my thrust is along the spinous process of that inferior vertebrae of the segment. So this would be to try and restore right rotation to this TL junction area. Now this particular thing is a little bit different from what we looked at before. So this is contralateral locking from above and below, thrust from above. So he is side bent right, rotated to the left, and from below he is side bent to the left. So what this does, this basically depends on what any sensitivities that your patient may have. If they can't be locked in one direction versus another, I'm just mainly giving you all these as options. Not that I do every single one of these on patients all the time, but again, just options. If one particular patient has a sensitivity with one type of locking, you can always go to something else. So for the upper body, the contralateral locking is side bent to the right, rotated to the left. And for the lower part, the lumbar spine area, it is side bent to the left because the pillow is positioned under their left foot, their left hip, which would, in the neutral position, tend to promote rotation the opposite. So my thumb, my thrusting thumb, is thrusting the superior vertebrae of the segment into further left rotation in this instance. Now this is more of a traditional technique that was shown from Maine and other things that you see in literature, where essentially my right arm is underneath both arms of the patient, wrapping around to the opposite side of the rib cage. And if this were, regardless of this is a female or a male patient, you would have a pillow placed between the patient's chest and your arm. So you can't see that here, but just know that you would have that. My left hand, I'm using my hypothenar eminence along the transverse process of that upper vertebrae of the segment that we're manipulating. And there's kind of a combination of translating the patient toward you with, in this instance, my right arm, and rotating them toward you, which would institute or initiate left side bending, right rotation. And a lot of times therapists will have the patient straddle the table at the end of the table. That way it helps further lock out the lower body. But obviously this patient is not doing that. But as you localize through side bending to the left, rotation to the right, and the tension developing under, in this instance, my left hand, the direction of the force is anterior, lateral, and slightly superior as well to give a minor distraction force as you're performing this manipulation. So pretty straightforward with that. It's pretty common that a lot of people have seen in ways to manipulate the TL junction here. Now, this is just, again, an alternate way of doing a couple of things. This is using a foam wedge, which honestly I like a lot better than a pillow or a towel, to help institute contralateral locking. Again, this would be right side bending and left rotation from below. And this would be contralateral locking above, where the patient is rotated to the right. Or excuse me, patient is going to be rotated to the right and side bent to the right, which you'll see in the next slides here. So this is the setup. From below, contralateral locking, and from above will be ipsilateral locking. So same position that you see here, very similar to the manipulation that we did earlier. The only thing that is different is he is rotated right, side bent right. And one thing that you'll notice is that I rotated him first and then side bent him to the right second. But the direction of the manipulation is very much the same direction as we mentioned before, which is anterior, lateral, and slightly superior. So again, we're going through and talking about all these different ways of doing different manipulations. This is contralateral locking from above, where the patient is side bent left, rotated right, and the thrust is from above. So same direction as we mentioned before. Anterior, lateral, slightly superior. No locking from below in this instance. This is a different technique, more of a seated distraction. So earlier on we showed you the old bone setter technique, where we used, I was turned around and had the patient lean back against me, pick him up off the floor, and you just drop them very rapidly by dropping your heels down. This particular is an alternative if you as a therapist are limited with your shoulder range of motion, or there's just such a difference in size, they're too tall for you to do that. So you'd have the patient sitting. In this instance, I'm using a mobilization wedge to stabilize that superior part of the segment. And you kind of grasp the patient like you might do the other sitting techniques with the lower elbow. And my abdomen is pressed against that mobilization wedge to stabilize that upper vertebrae of the segment. And if you have the table height correct, all you'd have to do is just lean back slightly and straighten your legs, and that would help lift the patient enough to do this technique. And then you would just drop your heels down similarly to what we did before to provide that distraction. Here, for safety, you see the patient has his legs crossed instead of being straight out, just to reduce any tension on the dura in this position, as well as the head and neck. You see the head and neck is not dropped down into flexion. It's at least in neutral, if not lean back against the therapist. Okay, so those are a lot of the manipulations. Sorry, like I said, we get into the weeds with some of those, but just wanted to go over many different alternatives in terms of position or locking, depending on what works best for you as a therapist or the patient. Further techniques that we can do are different mobilizations of the floating ribs. So these are different presentations you see depending on the direction of restriction. The picture to the left, the patient would be side bent away from you. So you'd be standing on the convexity of their body. Their feet are pushed away from you. Their upper body is pushed away from you. And on the picture on the right, it's just the opposite. Your position on the side of a concavity. But either way, you're mobilizing with one hand along those floating ribs, 11 or 12, and the other hand is along the ASIS, in which case you would be lifting up along the pelvis, and you can start by lifting to the point of tension and either have the patient resist or take deep breaths in and out, and as they relax, you take up slack. This is all, I'm sorry, the text got cut off here, but this is also a way to mobilize and help stretch the diaphragm. One of the things that this is particularly nice for is, as you saw back in the slides earlier in this presentation, the diaphragm and its various attachments can limit movement through this area. So we want to make sure that the diaphragm also has proper mobility. So if your patient is a typical patient, they probably don't breathe that well, and they probably don't breathe and provide full expansion of their rib cage or diaphragm when they do breathe. So this is a nice manual technique where you can use either your fingers with gentle pressure or your thumbs with gentle pressure along that lower border of the rib cage. The top picture shows the patient in supine. The bottom picture shows the patient in a quadruped position. That way, different ways of accessing these tissues. But your force would be, as they inhale, you follow their rib cage with your treating hands, and as they exhale, you maintain that position of the rib cage, and that would help to stretch the diaphragm tissues. So these pictures are techniques from the Institute of Physical Art coursework. Things to consider for poor technique, like I said, if you're not comfortable with something, you're not comfortable in your execution of the technique, these are things that may be happening. You're either using way too much force, and remember, you should only use as much force as you need to get the technique performed correctly. So that could change depending on the size of the patient or the stiffness of tissues. Too much amplitude, or you're getting a run at it where you're backing off too much from the barrier and you're just charging through and the thrust is too large of an amplitude. You're using too much leverage. So if you have a patient that is overly flexible, you're winding them up too much, or you're just applying too much locking through an area, or a different inappropriate combination of leverage or combination of locking. So that's one of the reasons why I gave you so many different options previously. If something is not right for the patient, they don't like it, or that's not feeling good, it gives you something to do as a backup. And then poor positioning of the patient, poor positioning of the therapist. You're not getting feedback from your patient. How's this feeling? Is this okay with you? Can we go ahead and do this little push or this quick push? Is that fine with you? Make sure that you're getting consent. Because if it's not a right setup, hopefully the patient will tell you, yeah, I don't think something's right, or can we do it a different way? And that'll a lot of times help to make the technique more successful. So we did have some case presentations to illustrate, but this isn't a great format to do that, so maybe we can do that on another time. And here are a list of my references. So thank you everyone for watching. I certainly appreciate this. Please let me know what you think in the comment section, or any of the social media that you see this, or on YouTube. I certainly appreciate all of it. Any constructive criticism that you may have, or if you like it and you want to see more of this stuff, please let me know as well, because it is kind of fun to do. So I appreciate the help. Appreciate you watching. You guys take care, and we'll see you again soon.